ఇప్పుడు మనం ఇప్పుడు నీకు అనిపిస్తున్నాను. హలో
Good
మ్యామ్, గుడ్
afternoon,
ఈవినింగ్.
everyone. I hope I'm audible.
ఎస్ మ్యామ్.
Good afternoon, everyone. Welcome to the educational webinar series from Vijaya Diagnostic Center. Today, we will be discussing about the newer classification of WHO, myeloid neoplasms, and a little emphasis on acute myeloid leukemia and its approach to diagnosis. As you all know, diagnosis and classification of acute myeloid leukemia has significantly changed in 2022 with the newly proposed WHO 5th edition. This predominantly emphasizes on the integration of clinical, molecular, genetic, morphological, and immunophenotypic parameters. Today we have our speaker, Dr. Sneha. She is MD Pathology from Siddhartha Medical College. She is going to present this. Over to you, Dr. Sneha.
Thank you, ma'am. Good afternoon, everyone. I'm Dr. Sneha. Today, I'm going to present a WHO 5th edition updates on myeloid neoplasms and a diagnostic approach to acute myeloid leukemia. WHO HEMAT5 is a systemic evaluation of the prior classification. The structure follows a lineage-based framework, following broadly from benign to malignant and branching down to category, family type, and subtype. So the flow type according to the lineage, then followed by dominant clinical attribute and the dominant biological attribute, which contains gene fusion, rearrangement, and mutations. So coming to the WHO HEMAT5 changes in myeloid neoplasms. So in this classification, attempt has been made to classify the tumors based upon the genetic abnormalities, and the new emerging entities are listed as a disease subtype under other defined genetic alterations. And the double colon marks has been used for the gene ions. Coming to the clonal hematopoiesis, the clonal hematopoiesis plays a major role in this WHO HEMAT5 classification. So, clonal hematopoiesis refers to a presence of population of cells derived from the mutated multipotent stem cells having the selective growth advantage in absence of any unexplained cytopenias, cancers, and other clonal disorders. So cytopenia, we know that cytopenia definitions, that is Hb less than 13 gram per dl in males and less than 12 grams per dl in females. Absolute neutrophil count less than 1.8 into 10 to the power of 9 for leukopenia, and platelets less than 150 into 10 to the power of 9 for thrombocytopenia. So coming to the changes in myeloproliferative neoplasms, previously chronic myeloid leukemia BCR-ABL positive has been renamed to the chronic myeloid leukemia, and chronic eosinophilic leukemia (NOH) has been converted to chronic eosinophilic leukemia. Myeloproliferative neoplasms unclassified has been changed to myeloproliferative neoplasms not other specified. Juvenile myelomonocytic leukemia, which was earlier in myelodysplastic myeloproliferative neoplasms, has been placed under myeloproliferative neoplasms. So coming to the changes in CML, we know that BCR-ABL positive has been removed from the name and the risk factors has been redefined. Accelerated phase is no longer required. So because of the presence of TKI therapy and careful disease monitoring, the incidence of progression to advanced phase disease has been decreased. Hence, accelerated phase has been omitted, emphasizing on high risk factors associated with chronic phase progression to the blast phase and resistance to the tyrosine kinase inhibitors. Coming to the polycythemia, the changes that has been seen in new edition is increased red blood cell mass has been removed. As a determination of red cell mass with 51 chromosome labeled chromium labeled red cells has become uncommon. It is in the routine clinical practice. It is no longer a diagnostic criteria. And the diagnostic criteria of chronic eosinophilic leukemia has been changed. The NOH has been removed, and the changes include the time interval required to define sustained hypereosinophilia is reduced from 6 months to 4 weeks, and elimination of increased blast as an alternative to the clonality, and addition of requirements of both clonal and abnormal bone marrow morphology, that is dysplasia of megakaryocyte and erythrodysplasia, is required for diagnosis. Juvenile myelomonocytic leukemia, that is called as MPN, myeloproliferative neoplasm of early childhood, which was previously in myelodysplastic or myeloproliferative neoplasms, which is now present in myeloproliferative neoplasms. The updated diagnostic criteria for juvenile myelomonocytic leukemia is there is exclusion of KMT2A and elimination of monosomy 7 from the cytogenetic criteria. This classification has emphasized more on particularly more on demonstrating RAS pathway activation. Coming to the mastocytosis, in systemic mastocytosis, bone marrow mastocytosis has now as a separate subtype. Previously, it was placed under indolescent systemic mastocytosis. Coming to the changes in diagnostic criteria for systemic mastocytosis, which has been modified, and CD30 expression and KIT mutation has been accepted as a minor diagnostic criteria. And bone marrow mastocytosis, which is characterized by the absence of any skin lesions, B findings, and basal serum tryptase below 125 nanogram per ml. The B findings and C findings have undergone minor refinements, that is KIT-PD 816V mutations with VF greater than 10% in bone marrow cells or peripheral blood leukocytes qualifies as a B finding. Coming to the changes in myelodysplastic neoplasms, previously it was called as myelodysplastic syndrome. It is converted to myelodysplastic neoplasm, and it is grouped under two categories, that is defining genetic abnormalities and morphologically defined. And previously there used to be single lineage and multi-lineage dysplasia. Now the term has been removed, and myelodysplasia syndrome unclassified has been removed, and refractory cytopenia of childhood has been converted to childhood MDS with low blast. So this is a new classification. In this, MDS with genetic abnormalities, that is MDS with low blast with 5q deletion, or MDS with low blast or SF3B1 mutation, or biallelic TP53 inactivation, which is placed under three categories, that is blast, cytogenetics, and mutation. And MDS with morphologically defined, it is divided into MDS with low blast, MDS with hyperplastic, and MDS with increased blast. Coming to the childhood myelodysplastic neoplasms, we know that it is a clonal hematopoietic stem cell neoplasm arising in the childhood and adolescents less than 18 years of age, ineffective hematopoiesis, cytopenias, and a risk of progression to AML. So in this childhood MDS, it is divided into two classes, that is childhood MDS with low blast and childhood MDS with increased blast. Coming to the myelodysplastic or myeloproliferative neoplasms, previously chronic myelomonocytic leukemia, the name doesn't change, but the diagnostic criteria has been updated very vastly. And atypical chronic myeloid leukemia, BCR ABL negative, has been converted to myelodysplastic myeloproliferative neoplasm with neutrophilia. And juvenile myelomonocytic leukemia has been now placed under myeloproliferative neoplasms. Myelodysplastic or myeloproliferative neoplasm with ring sideroblast and thrombocytosis has been renamed myelodysplastic or myeloproliferative neoplasms with SF3B1 mutation and thrombocytosis. Myelodysplastic or myeloproliferative neoplasms unclassified has been changed to not other specified. So coming to the diagnostic criteria of chronic myelomonocytic leukemia, there is a vast changes in the diagnostic criteria, that is prerequisite and supporting criteria has been added. With a persistent absolute monocytosis count has been lowered from 1 into 10 to the power of 9 to 0.5 into 10 to the power of 9. And abnormal partition of peripheral blood monocyte subsets are introduced in the new supporting criteria. And subtyping criteria, it is divided into two types, that is myelodysplastic CMML and myeloproliferative CMML based upon the WBC count. Previously, CMML 0 used to be there, that contains less than 2% of blast in blood and less than 5% of blast in the bone marrow, which has been eliminated because of limited prognostic significance. Coming to the acute myeloid leukemia, previously it was placed under four classification, that is AML with recurrent genetic abnormalities, AML with myelodysplastic changes, therapy-related changes, and AML myeloid leukemia NOS. It has been classified. It is separated into two categories, that is AML with defining genetic abnormalities, and AML with defined by differentiation. So AML with NOS has been removed, changed into the defined by differentiation. The changes in defining genetic abnormalities, 20% of cutoff, 20% blast cutoff is not required for all AML with defined genetic abnormalities except BCR ABL and CBP. And acute myeloid leukemia with other defined genetic alterations, which is placed as a new term in the defining genetic abnormalities. Coming to the AML with the defining genetic abnormalities, for APML with PML RARA, RUNX1, RUNXT1, CBFP, MYH11, and DKNUP214 and RBM15 or MRTFA, the diagnostic criteria has unchanged. But for BCR ABL fusion and CBP FPA, that at least 20% of blast diagnosis to avoid overlap with CML. And the recognized KMT2A rearrangements, MECOM and NUP98 rearrangements are recognized. Previously, KMT2A rearrangement has replaced KMT2A rearrangement has replaced AML with translocation 911. Now it is called as AML with KMT2A rearrangements. Acute myeloid leukemia, NPM1 mutations and CEVPM mutations, which has been placed under defining genetic abnormalities. Myelodysplasia. Previously, AML with myelodysplasia related changes has been now called as myelodysplasia related. And if any rare fusions are there, it was placed under other defining genetic alterations. Coming to the AML myelodysplasia related, it consists of greater than 20% of blasts and myeloid immunophenotype and specific cytogenetic and molecular abnormalities, which are associated with MDS, erasing de novo or following known as history of MDS or MDS MPN. The key changes are removal of morphology alone as a diagnostic criteria, update of defining cytogenetic criteria. Coming to the AML defined by differentiation, in this they lack any defining genetic abnormalities. Previously, AML with minimal differentiation, AML without maturation, AML with maturation, acute myelomonocytic leukemia, acute monoblastic and monocytic leukemia, pure erythroid leukemia, acute megakaryoblast leukemia, and acute basophilic leukemia, acute panmyelosis with myelofibrosis has been changed with AML with minimal differentiation, AML without maturation, AML with maturation, acute basophilic leukemia, acute myelomonocytic leukemia, acute monocytic leukemia, acute erythroid leukemia, and acute megakaryoblast leukemia. Previously, pure erythroid leukemia has been converted to acute erythroid leukemia. Secondary myeloid neoplasms. This is a new category of disease having a known predisposing factors. So it is divided into two categories, two classifications, that is post cytotoxic therapy or associated with germline variant. Myeloid lymphoid neoplasms with eosinophilia and tyrosine kinase gene fusions. Previously, myeloid and lymphoid neoplasms with eosinophilia and gene rearrangements. This has been renamed to myeloid lymphoid neoplasms with eosinophilia and tyrosine kinase gene fusions. JAK2 rearrangements with genes other than PCM1 has been recognized as a JAK2 rearrangement is now a distinct type. JAK2 rearrangements, FLT3 rearrangements, and ETV6 ABL1 fusion are considered as a novel type. And in other defining tyrosine kinase fusions, ETV6, all the tyrosine kinase fusions have been placed under other defined tyrosine kinase fusions. Acute leukemias of mixed or ambiguous lineage. So it is divided into two families: acute leukemia of ambiguous lineage with a defining genetic abnormality, or acute leukemia of ambiguous lineage or immunophenotypically defined. So coming to the diagnostic approach to the acute myeloid leukemia, we know that acute myeloid leukemia is a malignant clonal disorder which is originating from the hematopoietic stem cells characterized by the proliferation of truly differentiated blasts in the bone marrow. The predisposing factors are hereditary factors such as Down syndrome, Fanconi anemia, Bloom syndrome, and acquired factors such as ionizing radiations, therapeutic radiations, and diagnostic X-rays, and chemical reagents agents such as penicillin. Coming to the pathogenesis of acute myeloid leukemia, it might be due to transcription fusion factor deficiencies, nucleophosmin, tumor suppressor genes, activated signaling genes, DNA methylation genes, myeloid transcription factors, chromatin modifiers, and cohesion complexes. So coming to the investigations for the diagnosis of acute myeloid leukemia, we need peripheral smear and the bone marrow aspiration, followed by cytochemistry. Immunophenotyping consists of flow cytometry or immunohistochemistry, cytogenetic analysis such as FISH, and molecular genetic analysis such as RT-PCR. Before going to the investigations, we need patient's history and clinical symptoms. Why? Because in ALL, it is mostly seen in childhood, and in AML, it is seen in the old age group. And clinical symptoms such as disseminated intravascular coagulation is seen in acute promyelocytic leukemia, and gum hypertrophy is seen in acute myelomonocytic leukemia. Organomegaly and CNS metastasis is seen in TALL. So before going to the peripheral smear and bone marrow, first step is a peripheral smear and bone marrow aspiration. Let's have a brief about peripheral smear and the bone marrow aspiration. The peripheral smear and bone marrow aspiration, we see the myeloblasts or erythroblasts, monoblasts, or blast like promyelocytes, which constitute about greater than 20% of the cell. So, coming to the cytology of myeloblast and the lymphoblast, myeloblast the size is larger, but the lymphoblast is the size is lesser than that compared to that of myeloblast. And the cytoplasm is fine chromatin or moderate. But in lymphoblast, the cytoplasm is scanty. Orods may be present in myeloblast, which are absent in lymphoblast. And nuclear chromatin is fine nuclear chromatin, but coarse in the lymphoblast. Nuclei are prominent, that is 1 to 4. In lymphoblast, it is 1 to 2, but these are indistinct. There are other blasts which can be seen in peripheral smear in peripheral smear and the bone marrow. These are agranular myeloblast, and promyelocytes. So in myeloblast, it is divided to type 1, type 2, type 3. A granular myeloblast has got this has got basophilic cytoplasm with no granules, but in granular myeloblast there are granules which are greater than less than 20 percentage. In type 3 there are more than 20% of granules with orods. How to differentiate between granular myeloblast and promyelocyte is the presence of perinuclear half around the nucleus and eccentrically pushed nucleus. And monoblast contains basophilic cytoplasm, contains cytoplasmic vacuoles with one or two prominent nucleoli. And erythroblast is showing deeply basophilic cytoplasm with coarse chromatin and indistinct nucleoli. Megakaryoblast shows cytoplasmic blips. Coming to the morphological assessment, AML with so it is divided into AML with minimal differentiation. In this, blasts are negative for MPO and Sudan black B by cytochemistry, and expression of two or more myeloid associated antigens such as CD13, 33, and CD117. AML without maturation show greater than 3% blasts positive for MPO or Sudan black B and negative for NSE by cytochemistry. Maturing cells of granulocytic lineage which constitute about less than 10% of the nucleated bone marrow cells. And these are positive for myeloid associated antigens such as MPO, CD13, 33, and CD117. AML with maturation shows greater than 3% of blasts positive for MPO and Sudan black B by Sudan black by cytochemistry. Maturing cells of granulocytic lineage constitute greater than 10% of nucleated marrow cells. And acute basophilic leukemia, the blast and immature or mature basophils with metachromasia on taurodin blue staining. Blast are negative for cytochemical MPO, SBB, and SC stain. Acute myelomonocytic leukemia, which constitute about greater than 20% of monocytes and their precursors, and greater than 20% shows granulocytic cells, and greater than 3% of blasts are positive for MPO. Acute monocytic leukemia shows greater than 80% of monocytes and less than 20% of maturing granulocytic series. Acute erythroid leukemia shows greater than 30% of immature erythroid cells, and acute megakaryoblast leukemia shows blast express one or more platelet glycophorin, that is CD41 and CD61 and CD46. Coming to the cytochemical reaction in myeloleukemia, normally we do Romanowski stain for peripheral smear and bone marrow biopsies or bone marrow aspiration. In most of the cases, we don't find the morphological features same to that of the diagnosis. Then we follow the cytochemical reaction. In the cytochemical reaction, we see the myeloperoxidase. We use myeloperoxidase, Sudan black B, or specific esterase, which improve the diagnostic up to 90%. So in myeloperoxidase, Sudan black B, and specific esterase, these strains strongly positive for myeloblast. Non-specific esterase, which is a monoblast strong positive, and PAS is positive for lymphoblast, pronormoblast or erythroblast. Coming to the AML with recurrent genetic abnormalities, previously we have seen AML without any defined genetic abnormalities, that is only differentiated by the peripheral smear. Sometimes there are recurrent genetic abnormalities are there, and the cell morphology has been different than compared to that of normal one. So according to that of AML with recurrent genetic abnormalities, AML with translocation 821, which shows abundant basophilic perinuclear clearing, and a large pink granules, and increased eosinophils and dysplastic neutrophils and nuclear abnormalities. And AML with inversion 16 shows nucleus is folded, and cytoplasm shows abundant basophilic and vacuolated, increased dysplastic eosinophils, and increased monocytes and precursors. And there is AML with AML rara, hypogranular or microgranular, reniform bilobe, which contains orods, decreased granules, which contains abnormal promyelocytes. AML with translocation 911 shows abundant basophilic vacuolated cytoplasm, increased monoblast or promonocytes. AML with translocation 69, there has no characteristic blast cell morphology, but there is dyserythropoiesis, dysmegakaryopoiesis, and increased basophils. AML with inversion 3 shows multiple morphological changes. Blast without any differentiation, blast with megakaryoblast differentiation, blast with a mixed myeloid and monocytic differentiation. In this, there is a multilineage dysplasia with bone marrow fibrosis. AML with translocation 821 shows RUNX1 or RUNX1T1, which shows long thin rods, eosinophilic globules, and salmon-shaped basophilic border, and abnormal neutrophils, pseudochaetic Higasid granules. And AML with inversion 16 shows CBFB MYH11, which contains basophilic granules with large eosinophilic granules, and there is some peripheral basophilic granules, occasional vacuolization, and mildly abnormal characters. Coming to the acute promyelocytic leukemia, or with a translocation 1517 or PML rara, there are two types: hypergranular and microgranular, and nuclear morphological abnormalities such as coin and cone, asymmetrical dumbbell or classic blast. Acute promyelocytic leukemia with hypergranular variant shows heavy cytoplasmic granulations, generally strain with red or purple, and these are orods which can be seen, and there is a round to oval eccentric nuclei. Occasional clubs and indentations are seen. Acute promyelocytic leukemia with hypergranular variant. So in this there is a egg-shaped nucleus with abundant eosinophilic cytoplasm, and there is a few or cytoplasmic granules can be seen. There are folded and convoluted and marked irregular nuclear borders are seen. Coming to the acute megakaryoblast leukemia with translocation 1:22, RBM15 or MRTFA. In this, there is a round nucleus with a prominent 1 to 3 nucleoli. There is a fine reticular chromatin, basophilic cytoplasm with membrane blippings. AML with myelodysplasia related changes. In this erythroid series, there are intranuclear bridges, multinucleation, choriorrhexis, nuclear budding, and ring sideroblast. And granulocytic series shows a pseudoplagular hit hypolobated nucleus and large granular neutrophils, hypersegmentation, and rods are seen. And in megakaryocytes, there are multinucleation, hypolobation, mononuclear micromegakaryocytes, and widely separated nuclear lobes or corn ball megakaryocytes are seen. With the addition of after getting the bone marrow aspirations and bone marrow biopsies, the confirmation, the final diagnosis or confirmation diagnosis is done with the flow cytometry or immunohistochemical stains. So in this AML, otherwise non-specified, in this AML with minimal differentiation, which shows positive for CD34, CD117, and HLA-DR. And AML without maturation shows positive for CD33 and CD13, and AML with maturation shows positive for CD13 MPO positive and CD15 CD33 positive. Acute myelomonocytic leukemia shows monocytic markers and CD7 monocytic markers, CD14 and CD64, and monoblastic leukemia shows a positive for monoblastic markers along with CD7, CD56, and CD65, and acute erythroid leukemia shows positive for hemoglobin A, that is immature erythroid, that is CD36, and acute megakaryoblast leukemia shows megakaryoblast marker, that is CD41, and acute basophilic leukemia is positive for CD11B 123. So the panel for diagnosis of AML in flow cytometry. The initial panel consists of CD45, that is a weak positive in hematopoietic, and TDT positive shows hematopoietic. The CD117, which is seen in blast, with the with the division, the CD117 will be decreased. Then MPO is positive for myeloid lineage, and PAX5 is positive for B cell lineage, and CD3 is positive for T cell lineage. So in myeloid IHC panel, HLA-DR is a weak positive or negative in promyelocytic leukemia. CD6 state is positive in monocyte, and hemoglobin A is positive in erythroid leukemia, and CD61 is positive in megakardioblastic. So this is a flowchart for the diagnosis of AML in flow cytometry. Blastic morphology with weak or negative CD45. Then we have to follow. We have to do CD3, CDT, and CD20, PAX5, CD34, and CD117. If that is TDT positive and CD3 positive, it should be considered as a TLE, and then follow up with CD2, CD5, and CD4, CD8. If it is positive for CDT, CD20 negative, but CD78 positive or PAX5 positive, it is considered as a BAL, and followed with CD22 and CD10, and CD117, CD34. PAX5 negative or CD79A negative, it is considered as acute myeloid leukemia, then followed by MPO and CD68. If it is MPO positive with CD68, is considered as a myeloid leukemia. MPO positive with CD68 and might be myelomonocytic leukemia. If it is MPO negative and CD68, that is AML with monocytic leukemia. This is a case series showing there is a very big side scatter showing hypergranular blast with CD45, um, um, with a green color showing hypergranular blast, then followed by monocytes and lymphocytes. And there is a CD33 negative but CD13 positive, HLA-DR negative with a CD34 positive, and CD34 negative with a CD64 positive. This flow cytometry shows it is a acute promyelocytic leukemia. Coming to the fish is a combination of both molecular and cytogenetic analysis, which identifies a protein, any abnormality in protein, DNA, and RNA. Um, um, any RNA. So the fish is it is mostly used for it is mostly used for prognosis and the therapy related prognosis of the patient. It is less used for the diagnostic criteria. The IHC panel for fish for acute myeloid leukemia is inversion 3, MECOM, deletion 5q, deletion 7q, translocation 821, translocation 922, translocation 11q23, and translocation 1517, which is used for PML RARA. Inversion 16 for CBFP or CBFB and IH11 mutation, and 17p13 TP53. So this is a fish of fluorescent in situ hybridization of it, translocation chromosome 15 and chromosome 17. In this, we use a dual probe break apart probe. In this, normally in this fish we use cells. We make the hybridization cells in interface and metaphase, and then we add the probe. If there is any translocation, um, if there are any translocation, we will find the dual color. Um, so in this there are dual colors are seen. So it is a translocation of chromosome 15 and 17, PML with RARA. Coming to the cytogenetic analysis, genetic abnormality in translocation 822 and inversion 16, which has got favorable prognosis. Translocation 1517 or NPM1 or CBPA has got favorable prognosis, and translocation 911 KMT2A MLL-T2 has got intermediate prognosis. Translocation 9 inversion 3, translocation 122, RUNX1, and complex karyotype has got unfavorable prognosis. Along with the cytogenetic analysis, fish and RT-PCR is used for minimal residual diseases, minimal residues disease also. Coming to the summary, and if the patient has suspected for acute leukemia, we have to take the relevant clinical data, complete blood count, and leukocyte differential count, and we have to take the peripheral blood smear, bone marrow aspiration and core biopsy, and extramedullary tissue biopsy if it is required, and morphological evaluation, flow cytometry, immunophenotyping, and conventional cytogenetic analysis and appropriate molecular genetics of each study. If it is not showing any abnormality, it is considered as not a acute leukemia. If it is positive, it's considered as acute leukemia. And according to that, we have to find whether it is a lymphoblastic ALL or AML or mixed phenotype acute leukemia. So coming to that of acute myeloid leukemia, if we suspect any promyelocytic leukemia, we have to do rapid detection of PML-RARA and coagulation studies to evaluate the DIC, because transdendritic acid has been a very good treatment for the acute promyelocytic leukemia. And we should perform FNT3 ITD and core binding factors such as the translocation 821, RUNX1, RUNXT1, inversion 16, and translocation 1616 CEBFP MYH mutations, and should also perform NPM1 CEBPA RUNX1. And if it is adult case, we should perform KIT mutations, or if it is a pediatric, may perform KIT mutations. Thank you.
Thank you, Dr. Sneha. Uh, there's a crisp. This was a crisp, very short presentation. This myelin neoplasm is very vast. It's practically very difficult to cover in such a short time. To summarize, the WHO fifth edition emphasizes on the integration of all the clinical, molecular, genetic, morphological, immunophenotypic, and as well as cytogenetic evaluation. It provides and facilitates diagnosis, prognostication, and helps in the improvement of the treatment. So there's a these all these are required for the risk stratification of AML. With the integrated diagnosis for AML is always required. So the testing approaches should consider some of the important rearrangements which has better prognosis, and these should be the first target before the treatment begins. That is NAP1, KM2, KMT2A, SEPA mutations, and NPM1. These FISH, cytogenetic evaluation, RT-PCR, and NGS for AML panel are frequently done. Thank you, everyone.